Swayam Prabha. Digital India. Educated India.
Welcome to this session. Today's session will be on adrenal neoplasms. First of all, I would like to acknowledge the permission to use images from Robbins and Cochran pathologic basis of disease, courtesy the first author of the textbook, Dr. Vinay Kumar, and his support for our endeavor is always appreciated. So, this session includes adrenocortical neoplasms as well as Pheochromocytoma, that is one of the adrenal medullary neoplasms, and it will be studied under the headings of etiology, pathogenesis, morphology, clinical features and laboratory investigations. Multiple endocrine neoplasia would also be looked into very briefly. So, adrenal neoplasms can be subdivided into adrenal cortical neoplasms and adrenal medullary neoplasms. Under the cortical neoplasms, we have both adenomas and carcinomas, whereas under medullary neoplasms, we have pheochromocytoma and neuroblastoma. Only pheochromocytoma would be dealt with today, besides both the adrenal cortical neoplasms. So, remember that adrenal cortical neoplasms, all of them give rise to hyperadrenalism. So, what exactly happens and what are the different types of this? Let us have a look at that. So, it can be adenomas or carcinomas. Now, adenomas may be functional and they can produce Cushing syndrome or hyperaldosteronism. Now, how do they do that? Remember that the adrenal cortex is divided into three zones, that is zona glomerulosa, zona fasciculata and zona reticularis, or what we say G, F and R. Now, glomerulosa produces aldosterone, then your fasciculata produces cortisols, and the last one, that is reticularis, produces testosterone or sex hormones, both estrogen as well as testosterone actually. Okay. Depending on the type of cell that is predominant in the adenoma, we would get either Cushing syndrome if it is cortisol predominant, hyperaldosteronism if it is aldosterone predominant. But remember that most or almost all the cases of hyperaldosteronism are associated with adenomas only and not carcinomas, unless the hyperaldosteronism is a part of the other syndromes. In that case, even carcinomas you can get. Now, carcinomas, if functional, are mostly presenting with virilizing symptoms and also Cushing syndrome. Now, most of the cases are sporadic, but familial cases can also be there. Familial cases are thought to be Lee-Fraumeni syndrome, Beckwith-Wiedemann syndrome, Lee-Fraumeni associated with p53 mutation and Beckwith-Wiedemann syndrome associated with IGF-2 or insulin-like growth factor 2 imprinting. Adrenocortical adenoma, another mutation that has been seen often in adrenocortical adenoma is PRKAR1 or PRKAR1A mutation, and this has been found in carcinomas also. So, the adenoma carcinoma sequence may be there. Grossly, most of these adrenocortical adenomas are incidentals, also known as incidentalomas, and detected on autopsy because clinically they may be silent unless it is functional. Now, functional microadenomas producing hyperaldosteronism are usually very small and multiple or multifocal, seen mostly in females in the 30 to 40 age group. They are well circumscribed and yellow. Now, this pertains to slightly larger adenomas also, but usually it never exceeds a size of 2.5 centimeters. The adjacent cortex depends on whether it is functional and non-functional. Now, when a functional adenoma produces cortisol, the adjacent cortex would be atrophied, whereas in a non-functional adenoma, or if an adenoma is producing aldosterone, then the adjacent cortex is usually normal. So, microscopically adrenocortical adenomas comprise of a cell population which is similar to that of the normal cortex, in that the cells have eosinophilic to vacuolated cytoplasm and a vesicular nucleus which is small and oval or round, and mild or minimal endocrine atypia may be there even in a benign lesion, that is even in an adenoma. So, it is not a feature of purely malignant tumor or adrenocortical carcinoma alone. Now, how do we detect that? So, immunohistochemically, when we do staining for Ki67, if it is less than 5%, it is an adenoma. If it is more than 5%, it is a carcinoma or suspicious of a carcinoma. And at the same time, we can even do a special stain known as reticulin, in which the reticulin is retained in an adenoma. Other your immunohistochemical markers which are classical for adenocortical tumors are SF1, that is steroidogenic factor 1, as well as alpha inhibin. Adenocortical carcinoma meanwhile is associated with besides Prakar 1A, IGF2 and P53 mutation, as already mentioned. These are more often seen than the other mutations, that is CTNNB1 or beta catenin, MEN1. Now, grossly these are large, most often invasive, and greater than a size of 20 centimeters. They almost always efface or replace the normal cortex. Cut section is variegated as in almost all carcinomas elsewhere, and it has cysts, necrosis, hemorrhage, etc., and it is ill circumscribed. Rarely some small carcinomas can be there which may closely mimic adenoma, in which case it is very difficult to differentiate the malignant potential. Microscopically, these can be well differentiated to anaplastic, and sometimes you can even get spindle cells or giant cells, and most of the time the cells are quite large and with an increase in mitosis. And importantly, remember that the Ki67 percentage is more than 5, and it is associated with an increased IGF2 levels. Okay, Weiss criteria or Weiss score is used to detect malignancy, and in this 9 criteria, there of which 3 are major, and as of now even one of the major is present, then it is suspicious for malignancy. So, the clinical features of all adrenocortical neoplasms include marked increase in serum cortisol, but the serum cortisol levels are much higher in carcinoma as compared to adenoma or hyperplasia. Carcinoma also has a bimodal distribution in first and fifth decades. Cushing syndrome and virilism are more often seen in carcinoma, whereas as I mentioned earlier, hyperaldosteronism is more often seen in adenoma. Hyperaldosteronism is characterized by hypertension, which sometimes can be resistant to treatment, as well as hypokalemia, and then sometimes even cardiac complications, and even neuromuscular symptoms can be there secondary to the hypokalemia. Whereas Cushing syndrome has characteristic body habitus including round face, then buffalo hump, obesity, hirsutism, then your striae on the abdomen, easy bruising, very thin skin, etc. So, with these features in mind, the patient should be investigated for one of the adrenal cortical tumors, either an adrenal cortical adenoma or a carcinoma. So, now we move on to the progression of these tumors. So, especially carcinoma. Now, adenoma can progress to carcinoma, whereas carcinoma, local invasion and metastasis are the definitive and characteristic features of malignancy. Now, why this is important is that though the Weiss criteria or Weiss criteria is there for detection of malignancy, it is not definitive. Only when invasion, local invasion or metastasis are there, then only it is indicative of malignancy in an adrenocortical neoplasm. Venous invasion is common, especially the adrenal vein to the vena cava. Metastasis can be lymph node metastasis or distant. Lymph node is to the regional and to periaortic, whereas distant most often the lungs are the preferred site. Now, please do remember that adrenal cortex is also a seat for metastasis from various organs, especially small cell carcinoma, lung, etc. So, in such cases it is very imperative to do immunohistochemistry to detect whether it is a primary neoplasm or a secondary neoplasm, especially if the tumor is non-functional. In functional cases, of course, it is easier to detect the primary being in the adrenal cortex itself. Survival is usually for 2 years when adrenal cortical carcinoma has been detected. So, laboratory investigations, we investigate for all the peptides and hormones etc., which are secreted by the adrenal cortex, primary among them being glucocorticoids, the mineralocorticoids and the sex hormones. So, in glucocorticoids, normally in any individual there is a diurnal variation of serum cortisol. In case of tumors, functional tumors, the serum cortisol is elevated and the diurnal variation is not there. At the same time, because the serum cortisol is elevated secondary to an adrenal tumor, the ACTH levels are reduced. Then subsequently, you can do the dexamethasone test. In saliva, we can do cortisol test, or urine, free cortisol can be checked especially for 24-hour period. Mineralocorticoids, the most important is serum potassium level. There is usually hypokalemia. Now, initially it was thought that hypokalemia was there in all cases of aldosterone producing tumors in the adrenal cortex, but of late it has been detected that not all tumors of the adrenal cortex may produce hypokalemia. So, plasma aldosterone concentration or PAC, which is elevated, is compared the ratio of that with plasma renin activity, PRA is checked because PRA is reduced. So, this ratio should increase in case of tumors of the adrenal cortex. In urine also we can check for aldosterone, it is a 24-hour over a 24-hour period. Sex hormones is 17 hydroxyprogesterone and 17 beta estradiol levels, as well as total and free testosterone levels need to be checked. So, with these investigations we can detect whether it is a tumor from the adrenal cortex or it is a secondary hyperplasia in the adrenals. Next one is adrenal medullary neoplasm. So, this is composed of neuroendocrine cells, also known as chromaffin cells, and the surrounding sustentacular cells. These produce catecholamines, that is dopamine, epinephrine and norepinephrine, also known as adrenaline and noradrenaline. Now, remember that sometimes you can get these neuroendocrine sites, similar ones like in the adrenal medulla elsewhere in the body. So, these are known as extra-adrenal neuroendocrine site. So, extra-adrenal neuroendocrine site in combination with the adrenal medulla is known as the paraganglionic system or autonomic nervous system, which comprises both the parasympathetic as well as the sympathetic and the GI. So, in head and neck it is the ioticosympathetic. Now, this is associated with the sympathetic system, especially organs of Zucker-Candle, branchiometric and the intravagal. Pheochromocytoma is a tumor comprised of chromaffin cells and produces catecholamines, rarely peptides, that is hormones like ACTH as well as somatostatin. So, the clinical features will depend on how high the hormones are as well as the catecholamine levels. A rule of 10 is there as regards to pheochromocytoma is very important. Please do remember 10% of these tumors are extra-adrenal, where they are known as paraganglioma. Pheochromocytoma is the name given only to tumors of the adrenal medulla. Similar tumors comprising similar cells and producing similar effects, if they are present in extra-adrenal sites, it is known as paraganglioma. 10% of sporadic cases are bilateral, 10% of them are malignant, commonly extra-adrenal sites as well as with germline mutation. 10% of them are non-hypertensive, which means that the remaining 90% present with hypertension. So, these are the your familial syndromes. Initially, it was thought that only 10% of sporadic cases are familial. Now, it has been increased to 25% being familial, and the mutations are always your germline mutations. So, we have the MEN2. MEN2A as well as 2B, both are associated with pheochromocytoma, but the other features are different. Medullary carcinoma with parathyroid hyperplasia in MEN2A, whereas 2B has medullary carcinoma, muffinoid habitus and mucocutaneous ganglioneuromas. Then neurofibromatosis type 1 has neurofibroma in association with pheochromocytoma. VHL syndrome has pheochromocytoma and renal cell carcinoma, hemangioblastoma as well as pancreatic endocrine neoplasia. Then there are the paragangliomas, hereditary ones 1, 3 and 4 associated with gastrointestinal stromal tumor. Polycythemia paraganglioma syndrome associated with polycythemia. The gene involvement is different. The succinate dehydrogenase enzymes D, C and B are associated with the hereditary paragangliomas. VHL is of course the VHL gene, neurofibromatosis is NF1, then the MEN2s both A and B are associated with RET. We will see how these two are different much later. So, whenever there is a germline mutation, the tumors that is pheochromocytomas present in younger patients and they present usually as bilateral tumors. Now, these germline mutations can affect 3 lines, that is it can be the GFR your growth factor receptor pathway amplification involving the RET gene or the neurofibromatosis 1 gene or NF1 gene, or it could be hypoxia induced factor 1 alpha or 2 alpha. Now, whenever these genes are involved in any way, there is induction and stability of these genes, then this produces something known as pseudohypoxia. Then the succinate dehydrogenate complex comprising B, C and D, there is gain of function mutation. Okay. Besides mutation involving HIF1 alpha and HIF2 alpha, there are other syndromes in which the gene involved in degrading a particular of these, that is the HIF1 alpha in case of VHL is mutated, so it does not degrade. Whereas in case of HIF2 alpha, that is the polycythemia paraganglioma syndrome, it is EPAS1 where there is a gain of function mutation which prevents degradation of HIF2 alpha. In the succinate dehydrogenate complex mutations, there is upregulation of both HIF1 alpha as well as HIF2 alpha. So, grossly these pheochromocytomas can be small tumors or they can be very large, weighing from 100 grams to 4 kilograms. Mostly they are circumscribed and adjacent adrenal tissue is atrophied or stretched over the tumor. There may be hemorrhage especially in large tumors, and these tumors usually show lobulation because of trabeculae which run through the tumor. Cut section is usually yellow tan. In large tumors, these may replace completely the adrenals and may be associated with cysts as well as necrosis. Now, there is a peculiarity of pheochromocytoma. These cells will be containing catecholamines, and therefore, oxidation of this occurs with potassium dichromate application, giving rise to a dark brown color, and that is why these cells are known as chromaffin cells, and the reaction, the chromaffin reaction. Microscopically, typical pattern is the Zellballen pattern, that is the alveolar pattern which can be seen, can also see as nests of tumor, and these nests are surrounded by very small cells which are known as sustentacular cells. These tumors are highly vascular. The vascularity can be brought out by special stains like periodic acid Schiff or PAS stain. Okay. The neuroendocrine cells are moderate sized to large cells with abundant eosinophilic finely granular cytoplasm, which is positive with silver because they contain catecholamines. And pleomorphism may be seen, but this is not a feature of malignancy, please do remember. Giant cells on mitosis are also common. Rarely spindle or small cell type can be there. Now, this spindle cell and small cell type are usually seen when the tumor becomes malignant. Nuclei are round to oval and salt and pepper chromatin, which is typical of all neuroendocrine tumors. Prominent nucleoli is a rarity. So, salt and pepper chromatin with very small nucleolus, abundant eosinophilic granular cytoplasm in a Zellballen pattern, typical of Pheochromocytoma microscopy. Vascular and capsular invasion may be seen, but indication of malignancy is metastasis, whereas there is something known as pheochromocytoma of the adrenal gland scaled score, that is PAS score, and there are several criterias in this like small cells, spindle cells, nucleomonomorphism, mitotic activity which is very high, then vascular invasion, then your invasion of the capsule, necrosis, then pleomorphism, giant cells, etc. So, some of these features. So, they have given score of 2 or 1 to each of these features. So, you add up the features, and if the score is equal to or greater than 4, then there is a likelihood of that tumor being malignant, and the patient has to be followed up, as well as a search should be done for metastasis elsewhere. Now, as I said earlier, postulated aggressive factors include confluent necrosis, predominant spindle cells, and an increased mitotic activity. Metastasis, when seen, is usually through to the 3 L's and bone, that is lung, liver, lymph nodes, as well as bone. When you do the electron microscopy, characteristic neurosecretory granules are seen in the cytoplasm. These are electron dense, that is why we are able to see black structures here, and they are membrane bound. Immunohistochemistry is very typical, as you know, it is a neuroendocrine neoplasm. So, they are positive for neuroendocrine markers, that is synaptophysin and chromogranin, whereas the cells, supporting cells, that is the sustentacular cells, are positive for S100. This is a typical feature of both paraganglioma as well as pheochromocytoma. Clinically, 90% of them, as I have mentioned, are presenting with hypertension, where there is very high BP, and this could be as recurrent sudden episodes, or there is a sustained elevation in BP with few paroxysms. Whenever the sudden episodes occur, it is known as paroxysmal hypertension. So, this paroxysmal hypertension just occurring by itself without any systemic features is rare. Most of the time it is associated with systemic features, that is including cardiac, like tachycardia, palpitations, apprehension, sweating, chest pain. Then CNS manifestations like headache and tremors, abdominal manifestations including pain, nausea, vomiting. This is mainly because of the your hormones and peptides which are secreted by the adrenal medulla, and therefore by the pheochromocytoma, including epinephrine and norepinephrine, which gives a fight or flight response, and dopamine, which is responsible for anxiety attacks. Epinephrine and norepinephrine are produced by most of the tumors, or almost all the tumors, dopamine by some of them and not all. Okay, pheochromocytoma clinically presents with a classic triad of episodic headache, sweating and tachycardia. The causes include stress, that is exercise or emotional stress, tumoral palpation. In case of urinary bladder paragangliomas, it is micturition and postural alteration. These give rise to catecholamine release, and this subsequently can affect the various organ systems. Now, in the heart, an acute episode can occur of myocardial infarction and ventricular fibrillation. These in turn much later on when it becomes chronic or subsequent attacks can give rise to congestive cardiac failure and thereby pulmonary edema. Besides that, even cerebrovascular accidents can occur. These cardiac complications are together known as catecholamine cardiomyopathy, and these are thought to be due to 2 reasons, that is vasoconstriction of the coronary arteries because of the catecholamines, or direct toxic effect of these catecholamines on the heart. So, microscopically what we see is a focal lesion, that is only small areas are affected, not the entire heart. So, what do you see in that? What we see is necrosis associated with inflammatory infiltrate of lymphocytes, macrophages, and in chronic cases there can be interstitial fibrosis. All these in turn give rise to your arrhythmias because of dysfunction of the heart. Okay, the laboratory investigations of pheochromocytoma includes the detection of elevated levels of serum and urinary catecholamines and their byproducts. So, these would be fractionated metanephrines, vanillyl manlic acid, that is VMA, which is 3 to 4 times normal if there is pheochromocytoma, homovanillic acid, which is a byproduct of dopamine as well as dopamine. Now, if metanephrines are elevated, we can do the clonidine suppression test also, as given in the picture from one of the articles, as well as lastly serum chromogranin A levels are also elevated. So, when we get elevation of all these and this clonidine suppression test is positive, it is definite that the patient has a pheochromocytoma, which is giving rise to all the symptoms. Next, we move on to the last topic for this session, that is multiple endocrine neoplasia syndromes. Now, these are together known as MEN syndromes, and these MEN syndromes are of 4 types: MEN1, then MEN2 which has 2A and 2B, and MEN4. 1 and 4 are almost similar phenotypically, the only difference being in the genetic makeup. So, these endocrine neoplasias are characterized by proliferative lesions in multiple endocrine organs. So, this could be hyperplasias, adenomas or carcinomas. Distinct features include presentation at a very young age, multiple organ involvement either synchronously or at different times, multifocality in organs involved, precursor hyperplasia being seen, and whenever these tumors recur, they can be aggressive, or even carcinomas, when they occur, they can be aggressive. The first type is the Wermer syndrome, also known as MEN1 syndrome. It characteristically involves 3 P's, that is pancreas, parathyroid and pituitary, seen with an incidence of 2 in 100,000 people. The parathyroid involvement is usually as hyperplasia or as adenomas and presents as primary hyperparathyroidism, which is the single most important and initial aspect of presentation in these patients of MEN1, seen in 80 to 95% of the patients and presents in the age group of 40 to 50 years. The pancreas is characterized by aggressive pancreatic endocrine tumors which present with metastasis. You get multiple functional microadenomas. Most characteristically are 2 types, that is the gastrinoma and insulinoma. Gastrinoma produces Zollinger-Ellison syndrome. Insulinomas are responsible for hypoglycemia as well as for CNS manifestations. Okay, lastly, the pituitary, there is an anterior pituitary adenoma giving rise to prolactin secretion. So, it is known as a prolactinoma. Sometimes you can even get somatotroph secreting neoplasms which give rise to acromegaly. Other tumors have also been detected in MEN1 syndrome, and these include duodenal gastrinomas, carcinoids, adenomas of the thyroid and adrenal cortex as well as lipomas. MEN1 pathogenesis is because of the product of MEN1 gene, that is menin. This menin forms complexes with transcription factors. These transcription factor complexes are 2. The first one is JND in cell. Normally, it is responsible for activating transcription and proliferation of the cell, but when it combines with the wild type of menin which acts as a kind of tumor suppressor, so this gives rise to stoppage of the your transcription as well as proliferation in the cell. So, the cell stops proliferating. So, what happens if it mutates? If it mutates, the menin mutates and the JND combines with this, the transcription and proliferation is forever happening within the cell. So, the cell kind of becomes immortal. Whereas, the wild type menin, when it combines with KMT2A, overexpression of Hox gene is seen and this promotes transcription in acute leukemia. So, here it acts as a tumor promoter. MEN4 is similar in all aspects, the only difference being from MEN1 in the genetic factor, that is here it is CDKN1B mutation, and this downregulates P27. P27 is an important inhibitor in the cell cycle. Now, we move on to MEN2, that is multiple endocrine neoplasia type 2. The type 2 of these multiple endocrine neoplasia syndromes has 2 types, 2A and 2B. Both of them are associated with activated RET proto-oncogene, medullary carcinoma and Pheochromocytomas. Now, MEN2A is also known as Sippel syndrome and it is seen to have associated parathyroid hyperplasia along with medullary carcinoma and Pheochromocytoma. Now, medullary carcinoma is seen in 100% of these patients with Sippel syndrome. It is aggressive, multifocal and secretes calcitonin. In these tumors associated with MEN2A or Sippel syndrome, there is a RET gain of function mutation, whereas in MEN2B it is a point substitution in RET. Now, these are associated with medullary carcinoma and Pheochromocytoma along with mucocutaneous neuromas, that is in the skin, as well as the mucosa of the eyes, respiratory tract and the gastrointestinal tract, along with marfanoid body habitus. Medullary carcinoma in MEN2B is more aggressive than that seen in MEN2A. Management of all adrenal cortical neoplasms. In adenomas, it is excision along with the adjoining fat, because normally sometimes adrenal cortical cells can be seen extending into the adipose tissue around it. Carcinoma is staged first and then depends radical excision with or without chemotherapy and radiation. Pheochromocytomas, the most important aspect of this is control of this paroxysmal hypertension. So, both preoperative as well as postoperative control should be there. Along with that, you do the excision and neoadjuvant chemotherapy or radiotherapy, depending on whether the tumor has extended or whether a little bit has been left behind during surgery, etc. The management of MEN syndrome is complicated. First thing is, it depends on the type of tumor that has presented, the age of the patient, and it also involves a whole group of doctors as well as paramedical personnel. The management of tumors also depends on whether it is familial or sporadic. Now, what they usually say is that a medullary carcinoma, especially if it occurs in a younger individual, it is always better to screen the entire family for one of these MEN syndromes. Clinical trials are ongoing right now for treatment of different hyperplasias as well as tumors in these patients. So, with that we bring to end this session on adrenal tumors. So, before we conclude, let us summarize what we learnt in this session. So, adrenal neoplasms can arise both in the cortex and the medulla. The cortical tumors can be adenoma or carcinomas. Medullary tumors include Pheochromocytoma as well as neuroblastoma. Today we learnt only about Pheochromocytoma. Adrenocortical neoplasms, they afflict all ages. It has been noted that carcinomas have a bimodal distribution, first and fifth decades. They can be functional, producing hyperaldosteronism, Cushing syndrome or virilism. Sporadic cases are most often seen, but sometimes it can be familial. In familial cases, it is usually seen with Li-Fraumeni syndrome and Beckwith-Wiedemann syndrome. Li-Fraumeni with P53 mutation, Beckwith-Wiedemann with IGF2 involvement. These resemble normal gland histologically. Atypia is common. Carcinoma is defined by size, metastasis and local invasion, also by Weiss criteria. Prakar 1A is the most often seen genetic abnormality in adenomas. Pheochromocytomas synthesize catecholamine, which is associated with paroxysmal hypertensive episodes with systemic effects. Rule of 10 is very important here, that is 10% are extraadrenal, bilateral when sporadic, and malignant as well as non-hypertensive. Genetics involve two most important pathways. One is the increased growth factor receptor signaling pathway involving RET and NF1 genes, or increased activity stability of HIF. As such, mutations of HIF can occur, both 1 alpha as well as 2 alpha, or associated with non-degradation because of abnormality in VHL, EPAS1, as well as the third important pathway, that is the SDH mutation pathway. Grossly, these are small to large, can have hemorrhage, necrosis, etc. in the larger tumors, and stain dark brown, that is the chromaffin response when it is treated with potassium dichromate. Histopathologically, characteristic features are the neuroendocrine cells, they are moderate to large sized with stippled chromatin nuclei which are oval, inconspicuous nucleoli, characteristically seen in Zell-Ballen pattern. Malignancy is defined by metastasis, though we do use the PAS criteria to check which of these are suspicious for malignancy. The MEN syndromes or multiple neuroendocrine neoplasia syndromes, multiple endocrine gland proliferation is noted in these. MEN1 is associated with menin tumor suppressor gene. It is seen to be involving the parathyroid, the pancreas and pituitary, also duodenal gastrinomas. MEN4 is similar, but the genetic abnormality here is of CDKN1B, which causes P27 to be abnormal and therefore cell cycle inhibition to be removed. MEN2A, also known as Sippel syndrome, has RET gain of function mutation. There are 2 Ps and 1 M in this, that is Pheochromocytoma. medullary carcinoma thyroid and parathyroid hyperplasia. Lastly, the MEN2B is associated with missense mutation in RET proto-oncogene. There are 3 Ms and 1 P. The 3 Ms include medullary carcinoma thyroid, mucocutaneous neuroma, marfanoid features, and the single P including pheochromocytoma. So, with that we come to the end of this session. Thank you for a patient hearing. Thank you.